So next I'd like to introduce Claudia Morris, who will share her expertise on nutritional interventions for specific disorders. In this particular case, it's her research on arginine therapy. She also provides a unique perspective as a pediatric emergency physician in Georgia, I believe.
Yes, at Emory.
Welcome at Emory. Thank you.
Thank you so much, Nessie. Where's my pointer? So I'm going to need that. Okay. All right. Well, thank you very much for that introduction, and it is an absolute pleasure to be here and to be part of this important forum. Okay. How do you make it? So, oh, that one, the green arrow. Okay. Okay. So, yes, I am an emergency medicine physician. Most people scratch their head wondering what I'm doing talking about nutritional interventions. But I think as everyone in this room knows, essential amino acids are dietary dependent, whereas non-essential amino acids are not. But then there's the conditionally essential amino acid, the non-essential amino acid that becomes indispensable under stress and critical illness, where the capacity for endogenous synthesis is surpassed. And we're going to talk specifically about arginine and how it plays a role in sickle cell disease. But there's a number of conditions that are linked to acquired arginine deficiencies, from trauma, critical illness, pregnancy where it's probably protective, and then hemolytic disorders such as sickle cell disease. So arginine is naturally found in the diet, high concentrations in meat, dairy, seafood, nuts. It's also found in watermelon. A normal adult ingests about 2 to 7 grams a day. So a lot of the cardiovascular studies and our sickle cell studies utilize 7 to 10 grams 2 to 3 times a day. So it's really hard to get enough from the diet. It's a nutritional supplement with a low toxicity. It's also being marketed in the supplement world as the natural alternative to Viagra. So now that you guys know that, you're never going to be able to look at watermelon the same way. So ultimately, it's the obligate substrate for nitric oxide production. And nitric oxide is one of the most potent vasodilators, so it plays a role in blood pressure modulation, but also inhibits platelet aggregation, has an immune response, anti-inflammatory properties, and can be a signaling molecule. And it's made by the enzymatic action of the nitric oxide synthase enzyme. But then there's arginase, which also competes for arginine as its substrate. And arginase is an important enzyme in the urea cycle. There's 2 mammalian isoforms, arginase 1, and let me see. Does that work? Whoops. Sorry. I lost my, okay. I lost my pointer. Sorry. Here we go. Okay, so 2 mammalian isoforms. You've got arginase 1, which is cytosolic, and arginase 2, which is mitochondrial. So I want to point out that they're intracellular enzymes. And they're present in most cell types, including the red blood cell, which makes it a really intriguing enzyme to study in hemolytic disorders where it's going to get dumped into circulation in a physiologic active form. It's also induced from inflammation and cytokines, and ultimately arginase will compete with nitric oxide synthase for their common substrate of arginine. So in the presence of arginase, arginine is converted to ornithine and urea. And what's interesting is that arginine and ornithine use the same amino acid transporters, CAT1 and CAT2. So when you increase your ornithine activity, you competitively inhibit your arginine bioavailability, which is going to translate to decreased nitric oxide bioavailability. So this is just a nice figure to kind of sum up some of the metabolism of the arginine processes. So here we have arginine getting converted to nitric oxide by nitric oxide synthase, and then you have substrate competition by arginase that converts arginine to ornithine. Sorry. And then you have the downstream byproducts of arginase activity, polyamines and prolines, and this is a proliferative pathway. And I'm going to be talking about pulmonary hypertension as one example of the pathophysiology that develops in the state of an arginine deficiency. But polyamines are involved in vascular smooth muscle proliferation, airway remodeling. Polyamines play a role in collagen production, deposition, lung fibrosis, airway remodeling, the kind of structural changes that you see in pulmonary hypertension and in asthma, common complications in sickle cell disease. So when we talked about arginine being semi-essential, it's because the body has the ability to synthesize it from the intestinal renal axis. So it's taken up from the diet, and glutamine gets converted to citrulline in the small intestine, and then citrulline gets converted to arginine in the kidney. And what's interesting is glutamine actually was just recently FDA approved for the treatment of sickle cell disease. It's the first FDA approved It's considered a drug for pediatrics and only the second FDA-approved drug for adults. And it actually is an arginine prodrug. So we talk about arginine bioavailability. There's so much more than just the amount of arginine that's in the plasma. So you have to take into account the effects of arginase and renal dysfunction. So we coined the term global arginine bioavailability ratio, which is the ratio of arginine over ornithine plus citrulline that takes into account a number of different effects. So when we talk about amino acid deficiencies, so a drop in an amino acid does not necessarily clinically translate to a clinically significant deficiency. So for a nutritional deficiency to be present, you need a biological process that's dependent on the nutrient that's compromised. That compromise needs to lead to abnormal physiologic response. It's causative of a poor outcome, and poor outcome needs to be reversed by that amino acid replacement. And ultimately, sickle cell disease is an excellent model for distinctive nutritional requirements that develop from a metabolic process, mainly hemolysis in this case. So when we talk about the biological process, so endothelial dysfunction, I'm going to talk over here. Endothelial dysfunction develops in the presence of low arginine bioavailability. The abnormal physiologic response, we're going to use pulmonary hypertension as a model, and pulmonary hypertension is associated with increased mortality in our patients with sickle cell disease, and poor outcome reversed by amino acid replacement. I'll show you some data where we supplemented with arginine, we're able to reverse pulmonary hypertension. So for those who aren't hematologists in the audience, so arginine is sickle cell disease is an inherited disease of the red blood cells. It's autosomal recessive, so you need to get a gene from both parents. Ultimately affects your hemoglobin, where you have hemoglobin polymerization that leads to a cascade of effects that ultimately decreases your blood flow. And it leads to tissue hypoxemia that causes both acute and chronic damage that affects pretty much every organ system in the patient with sickle cell disease. So, and it actually is an orphan disease. It affects about 100,000 individuals in the United States, but millions of people are affected worldwide, and it comes at a significant economic cost. So why do the sickle cells sickle? Well, it's a single point mutation, a substitution of valine for glutamic acid on the 6th position of the beta subunit of the hemoglobin molecule, that you end up with polymerization of the sickle hemoglobin under stress and deoxygenated states that gives it that classic sickle shape. But it's interesting because the clinical phenotype of sickle cell disease comes across a long spectrum from mild to severe, much more than you would expect from a single point mutation. So there's a lot of other factors that come into play that contribute to disease severity. So sickle cell disease is also a model of vasculopathy and endothelial dysfunction. Not only do you have hemolysis, but you also have inflammation that translates to nitric oxide and arginine depletion. And this is just a model. There's a number of different mechanisms that contribute to vasculopathy and sickle cell disease, but this could be a model for any condition of hemolysis. And you have a depletion of nitric oxide taking central stage here. So when you have hemolysis, normally packaged within that red blood cell is all the contents of the red blood cell. So when it breaks apart, you end up with a dumping of cell-free hemoglobin into circulation, which rapidly consumes nitric oxide. There's also arginase in the human red blood cell. We don't know what it does, but that gets dumped into circulation. It will rapidly consume the obligate substrate for nitric oxide production. So as your arginine level depletes, you end up with dysfunction of the nitric oxide synthase enzyme. It uncouples, begins to produce superoxide in lieu of nitric oxide, further consuming nitric oxide and adding to this milieu of oxidative stress. And so what you see is really a global dysfunction of the arginine nitric oxide pathway, and many of these things are actually occurring simultaneously. So also within the red blood cell is LDH, lactate dehydrogenase, and although we think it's of no clinical relevance, when it gets dumped into circulation, it makes a really nice biomarker of the hemolytic subphenotype of sickle cell disease. And there are clinical consequences of decreased nitric oxide bioavailability. You have endothelial activation, increase of endothelial 1, which is a potent vasoconstrictor, platelet activation, and ultimately the clinical manifestations. So I'm focusing on the pulmonary complications, pulmonary hypertension, but there's asthma, stroke, renal insufficiency, priapism, and leg ulcers. So again, you could, even though I'm focusing on pulmonary hypertension, you can insert any of these complications. And this is known as the hemolytic subphenotype of sickle cell disease, but it is also the clinical phenotype of low arginine bioavailability. So what we found a few years ago was that there's an arginine insufficiency and elevated arginase activity in patients with sickle cell disease. So you have, here's your plasma arginine in the sickle cell patients compared to normal controls. Arginase activity in the plasma all over the map, but very, very high compared to levels that are barely measurable in normal controls. So as I mentioned earlier, arginase is an intracellular enzyme. So it's only released upon cell damage or cell death. It just shouldn't be in your plasma if you're a healthy individual. So then we looked at the Arg-to-Orn ratio as a biomarker of arginase activity, because as I mentioned, arginase converts arginine to ornithine, and there's low Arg-to-Orn ratio in the sickle cell patients compared to normal controls, but here's where it got interesting, was that the lowest levels were found in the patients at highest risk for pulmonary hypertension. So now I started paying more attention to pulmonary hypertension. The next we actually figured, well, if it's low, give it back. So this is a small study where we actually that didn't, something happened to my figure there. But you can still see that there was a pretty impressive decrease in pulmonary systolic pressures estimated by echocardiography of over 15%, which is actually pretty similar to what you see by some on-the-market pulmonary hypertension medications. So here was the pre-treatment pulmonary systolic pressures, and here was their post-treatment. So we were actually very excited about this, but the anecdotal observation, though, was also that 2 of these patients had chronic leg ulcers that they had been experiencing for years, and nothing seemed to be helping them. And of interest, within the 5 days, their leg ulcers also started to heal. So it seems that we have this condition of endothelial dysfunction manifesting as pulmonary hypertension that seems to be reversed with arginine therapy. And not every patient with sickle cell disease develops pulmonary hypertension, so it's about 10% of the population. So our next step was to think about, well, we also have another hemolytic anemia, thalassemia, that is associated with a high prevalence of pulmonary hypertension. So we looked at some of our patients in the thalassemia clinic, and what was interesting is we found a similar pattern of arginine dysregulation in our thalassemia patients. So here you have arginase activity, high in some patients but normal in others, but higher than normal controls, low Arg-to-Orn ratio, and elevation in the downstream byproducts, high citrulline levels suggesting that there may be problems converting citrulline to arginine. But then, 10 years later, we had learned quite a bit about pulmonary hypertension. We went back to the thalassemia clinic and actually looked specifically at patients who were at risk for pulmonary hypertension versus those who had normal Doppler echo. And what was interesting is that the patients who had dysregulation of their arginine metabolism were the patients who were at risk for pulmonary hypertension. So here you have a tricuspid regurgent jet velocity of over 2.5 meters per second on Doppler echo compared to normal, which is less than 2.5. So some of these thalassemia patients had completely normal arginine levels. But if you were at risk for pulmonary hypertension, you had low arginine, you had very high arginase activity compared to the thalassemia patients who had a normal echo, low Arg-to-Orn ratio, and a low global arginine bioavailability ratio. And it appears that the cardiopulmonary dysfunction of these patients correlated strongly to biomarkers of hemolytic rate. So again, bringing it back to the concept of hemolysis. But what was really fascinating was the fact that low global arginine bioavailability was associated with increased risk of death, as reflected by the Arg-to-Orn ratio, but also the Arg-to-Orn plus citrulline ratio, that global arginine bioavailability ratio we talked about earlier. So what we had, these are tertiles, and there were no deaths in the patients who had the highest arginine bioavailability, and the most number of deaths in the patients who had the lowest arginine bioavailability with a risk ratio of 3.6. And this has actually been found now also in children with sickle cell disease in Tanzania, and also low arginine bioavailability predicts early mortality in patients with malaria. So then, Stan Hazen, who actually collaborated with us running the amino acids, he was a cardiologist at Cleveland Clinic, actually looked within a cohort of patients who were at risk for cardiovascular disease. So nearly 1,000 patients who were undergoing right heart cardiac cath, and he found that reduced global arginine bioavailability ratio is associated with increased incidence of MACE. So he obtained a blood value looking at their arginine bioavailability and followed them over 3 years. And so here are the quartiles. So yellow is the lowest arginine bioavailability, blue is the highest arginine bioavailability, and you can see significant increase in major adverse cardiovascular events. And those events that he looked at were death, myocardial infarction, and stroke. So again, this suggests that arginine bioavailability, the other thing he found is that this ratio is actually more predictive of cardiovascular disease than cholesterol. So, which suggests that, one, this is important for survival, but it's also a biomarker of vasculopathy that goes beyond sickle cell disease. So there's a number of different mechanisms of arginine dysregulation. We've talked about some of them, and many of these are actually happening simultaneously. But there's a common theme to these arginine deficiency syndromes, and it's very often excess arginase activity. So whether hepatic, immune, or from hemolyzed red cells during hemolysis or transfusion reactions, the clinical consequence of excess extracellular arginine is similar regardless of the cellular origin. So once it's in the system, it's going to have physiologic effects. And there's really two basket conditions that I think about with arginine deficiency syndromes: endothelial dysfunction, using sickle cell disease as a model, and then T-cell dysfunction, using trauma as a model. So I'm going to change gears just a little bit. It's not blinking yet. T-cell dysfunction is linked to acute nutritional deficiencies in trauma patients, and this is of interest to me as an ER doc because we're the first to see the trauma patients when they come in. Arginine is essential for naive T-cell activation, and T-cells are exquisitely sensitive to arginine depletion. So T-cell proliferation is blunted, T lymphocyte-mediated cytotoxicity and memory responses are nearly completely abolished when you deplete arginine. And again, as I mentioned earlier, this could be protective under conditions like pregnancy, where you really need to suppress your immune system to protect the baby and the mother. But the provision of arginine to culture media restores T-cell function. So again, give it back and you fix the problem. So there's over 15 million injuries a year in the United States, and about 10% of trauma patients develop wound infections. Infection risk increases to 30% for patients who are in the ICU for over 48 hours, and infections are the leading cause of late organ failure and contribute to 10% of trauma deaths. Now, what we know is that there's decreased plasma arginine levels in trauma that occurs in minutes to hours and of the traumatic event, and it can remain low for even up to a week or longer. And actually, one of the pioneers in the field is actually sitting in the audience, Juan Ochoa, back when he was the trauma surgeon at University of Pittsburgh, and he actually helped us understand that there's increased plasma arginase activity in our trauma patients, and the source is myeloid-derived suppressor cells that express arginase 1 after trauma. So in sickle cell disease, you have the red cells dumping arginase from hemolysis, but in trauma, you've got a different cell source, but ultimately increasing your arginase and leading to an arginine deficiency. So this depletes arginine, ultimately translates to T-cell dysfunction, but in a trauma patient, this is going to increase your susceptibility to infection after an injury. So strategies that are aimed at infection prevention after trauma should result in significant decreased mortality, morbidity, and cost. So what do we know about the therapeutic potential of arginine? Well, in sickle cell, there's been actually many studies over the last 20 years. So in the mouse model, arginine supplementation improves perfusion, increases glutathione, so has an effect on oxidative stress, decreases inflammation, improves lung injury, reverses microvascular vaso-occlusion, and improves mortality in the sickle cell mouse model. What's interesting about the sickle cell mouse model is, though, that they don't have arginase in their red cell like humans do. But they do have increased arginase activity. It's just coming from a different source. So there have been several positive human studies as well, phase 2 trials showing that arginine improves leg ulcers. We published a vaso-occlusive pain trial where children with sickle cell disease admitted to the hospital were treated with arginine versus placebo, and we saw a decrease of over 55% in opioid use, lower pain scores at discharge. We're now working with the FDA to complete a second phase 2 trial with our eyes on a phase 3 multi-center. And then I showed you the data with decreased pulmonary hypertension, sickle cell disease, and anecdotally, arginine therapy will acutely improve priapism in the emergency room for the few times that I've actually used it. So what about trauma? Well, arginine therapy enhances wound healing after trauma and hemorrhagic shock. And immunonutrition improves immune responses and T-cell function. High arginine formulas have been shown to decrease infectious complications in critically ill patients, and the benefit is the greatest in the surgical patients. But there is evidence of harm, so we have to approach this with some equipoise in sepsis and following acute MI, so we don't have all the answers yet. But there have been lots of methodologic weaknesses in most of the studies, and there's a paucity of data in children. So what do we know about immune nutrition in critically ill children? Well, in 2009, and this was shocking to me, in 2009, Cochrane reviewed Cochrane review found insufficient evidence for or against nutritional support in children during the first week of their critical illness, mainly because the appropriate studies were not performed. So no evidence that we should be feeding the sickest children that we're dealing with in the hospital. So some PICU doctors have interpreted this as don't feed them. And there are children who are with delay feeding that we're starving these trauma patients. Even though there's a push to try and increase earlier enteral feeds, it really has been lost at a lot of centers, and they feel that this is not something that they should be paying attention to. So just cruising the literature, I did find one single randomized controlled trial of arginine glutamine fortified formula in 40 ventilated children with traumatic brain injury. Their primary outcome measure was mortality. Now, less than 10% of these kids died, so this was severely underpowered for their primary outcome, and they found no difference in mortality compared to standard formula. But what I found the light was this positive nitrogen balance by day 5 and 69% versus 31% of the patients who got the fortified formula. And the reason I think this is important is because there have been studies out there. There was actually a recent study in surgery also by the same group. They found that critically ill patients, they looked at over 1,000 patients, a multi-center study, they found that a decreased 60-day mortality occurred in patients who had adequate protein intake. So when they looked at less than 20% versus over 60% of the prescribed goals, this was associated with an odds ratio of 0.14 for 60-day mortality. So this certainly gives me pause. And it also suggests that we've gotten it wrong all the years. It's not overall calories, but it's enteral protein delivery. So basically, by achieving delivery of over 60% of protein goals are associated with decreased mortality in mechanically ventilated children, and now they've also just published data showing in surgical trauma patients as well. So ultimately, enteral protein delivery is a modifiable risk factor for mortality that's in dire need of a shift in our current practice, given the potential for improved outcomes. So therapeutic strategies, certainly arginine supplementation, but we can also look at arginine precursors such as citrulline and glutamine. And then, of course, my bias is that combination therapies hitting multiple mechanisms makes more sense. Immunonutrition, targeting enteral formulas, the concept of personalized medicine to address these unique nutritional requirements. But the ideal formula for trauma, critical illness, pediatrics do not yet exist. Oh, I don't know what just happened. And more research is needed. So just the key points to tie up: arginine is a conditionally essential amino acid that under conditions of stress and catabolic state becomes essential when the capacity of endogenous amino acid synthesis is exceeded. This includes situations such as critical illness, trauma, and hemolysis, among others. Sickle cell disease and trauma represent arginine deficiency syndromes, and they have a distinct nutritional requirement that develops because of their metabolic abnormalities that may benefit from arginine replacement therapy. And there's at least 2 broad categories of arginine deficiency syndrome: T-cell dysfunction, which trauma is a nice example, and endothelial dysfunction, for which we used sickle cell as an example. And arginine-fortified immunonutrition may be a treatment for acquired arginine deficiencies. Certainly we need further study to identify subpopulations who will benefit most while minimizing potential adverse events. And then I'll leave you with my bias that nutrition is medicine. Thank you very much.